introduction. We are going to kick it off with a brief presentation. So as DA Ryan mentioned, the presentation that we're going to give today is mostly focused on our work monitoring COVID-19, but we'll be back at a subsequent meeting to really get back into where we're at with our work monitoring opioids and other high-risk substances in wastewater. And one of the things that we wanted to talk with you all about today that we think could be of interest to this group is the wastewater epidemiology work that we're doing specifically at the building level. And we'll get into exactly what we mean by that and some of the applications, but really looking at wastewater epi beyond just wastewater treatment plants and looking at very large catchment areas like, if you're familiar with the data that we've been generating at Deer Island, which represents about 2.2 million people in the greater Boston area. But actually what we can do with this technology and with this approach, if we move upstream into smaller catchment areas like a jail, a university building, campus, a place of work, a nursing home. So with that, I'll kick it off and then pass it to my colleague, Scott Olson, to introduce himself and continue. So if we can maybe go to the next slide, please, Scott. So as DA Ryan mentioned, BioBot is a spinoff from MIT. It was founded by myself, Nusha Gailey, as well as Mariana Matus. And the work was really bringing together the research work that we started in 2014 was bringing together Mariana's background in computational biology and microbiology together with my background in architecture, engineering, and really the urban landscape. So looking at how we can leverage technologies to build better cities ultimately. And we see a healthier city as being a better city. It's really as simple as that. So next slide, please. And as you're all aware, we started the company in 2017 by addressing the opioid epidemic. And this was really the place that we decided to start because, first of all things that we consume, whether it's food, medications, drugs, licit or illicit, are metabolized in our bodies and excreted in urine. And when we started the company, we knew that we could measure chemicals, so drugs that are excreted. We knew we could measure human viruses, infectious disease viruses, bacteria. And in 2017, in order to decide what to focus on, we asked as many public health and government officials as we could, what is your number one public health, priority today? What is highest on your agenda? And we got the opioid epidemic across the board. And so in 2017, we designed very much our first application and our first product focusing on measuring opioids, so heroin, fentanyl, illicit opioids, as well as about 24 prescription opioids in wastewater to help public health agencies and communities really shift from looking at overdose deaths as the gold, or overdoses, non-fatal overdoses as the gold standard by which they evaluate the severity of substance use disorder in their community, to looking at consumption in near real time. And so that was our hope. And this product or this application, we scaled to working across cities and communities in North Carolina and in Massachusetts. And in January of 2020, so right before everyone was completely consumed by COVID, we launched actually this work across the state of Massachusetts with support from Governor Baker, Secretary Sutters, and the Massachusetts Department of Public Health. We were very excited to launch across 7 cities in the state of Massachusetts in January. And then as with the rest of our opioid work, we sort of paused that in March of 2020 when, COVID really kind of demonstrated that it was surpassing kind of everything else in terms of what public health was focusing on. So in February 2020, actually, we pivoted and expanded our work and to focus on COVID-19. And in the span of about 4 weeks, our team developed the assays to measure and quantify, to detect and quantify the SARS-CoV-2 virus in wastewater. And from there, we put out an open call to communities across the United States, soliciting wastewater samples to test for free. We thought that, this would be a great way to generate some additional data, especially very early on in the pandemic. We were under testing, and so we thought that this data could help fill a gap. And we put out an open call, and we were overwhelmed with interest. And since then, we've tested for SARS-CoV-2 or COVID-19 in sewage across almost 400 sampling locations. So both at wastewater treatment plants as well as building level environments, which we'll get into in a second. We've worked in every single state in the US. So really growing with the opioids in just North Carolina and Massachusetts to now having worked in every single state, a handful of US territories, as well as expanding into Canada slowly. And to date, we've tested almost 10,000 samples for SARS-CoV-2, representing about 30% of the US population. And one of the things that I want to highlight before I pass it over to Scott to introduce himself is that one of the things that we've seen over the past 18 months is that wastewater epidemiology is a solution and a technology that's relevant and applicable to cities of all sizes. Oftentimes we see innovative and smart cities types of solutions being mostly relevant to very large urban centers, wealthier cities. But that's not what we've seen here. And we've actually seen greater adoption in smaller communities. And we see a particular sort of value add when it comes to wastewater epi when healthcare resources are limited, because that's the value that we've seen in wastewater epi, is that it complements and enhances clinical data. And so when clinical data is limited, wastewater data can really help fill that gap. So with that, I'm going to pass it over to Scott to introduce himself and talk a little bit about our building level work.
Yeah, great. Thanks, Nisha. My name is Scott Olson. I'm a computational epidemiologist at BioBot. My training was in antibiotic resistance and the microbiome. So I was real excited to be working with BioBot on this work. As Nisha mentioned, the thing we wanted to talk about today was about wastewater monitoring at the level of buildings. And what we're showing here is a list that I think Nisha had mentioned at the beginning, but there's all sorts of kinds of building level communities that have reason to measure COVID-19 and monitor COVID-19 activity among their populations. I think for this group, the congregate places of living will be a bit more interesting, but we have things that go all the way, BioBot has worked with, and there's reports in the scientific literature about everything from correctional facilities, senior living homes, universities, all the way to things that are not congregate living settings, but where there's still value in having some measure of whether or not folks are infected, like a school or a place of work, in the attempt to limit transmission in those settings. The appeal here that Nusha touched on was that at the building level and at the community level, but especially at the building level, wastewater is this non-intrusive testing option. So there are certainly communities and facilities that have the resources and kind of the social capital to do nasal swabs on everybody or some fraction of people who are in the community on some routine basis, with the intent to monitor and make sure that outbreaks, monitor COVID-19 activity and avoid any outbreak. But there's a lot of disadvantages to the diagnostic tests. They're inconvenient, they're invasive and unpleasant. I'm sure we've all done our fair share by now. And so at some point you end up with testing fatigue. Folks would just rather not have to do this on any kind of regular basis. Everything that I say after this, I just want to emphasize that wastewater monitoring is a complement to diagnostic testing. Diagnostic testing is the only way to determine if one individual person is infected or not. And if wastewater gives you some signal that makes you think that something is going on, often then the step that the facility will take or the community will take is to swab a bunch of people to determine who's infected and how the chains of transmission of COVID-19 can be broken. So I just want to say, none of what I'm going to say is to say that there's no place for nasal swabs, but just all of there's problems with using them for routine surveillance and screening. Wastewater, on the other hand, is passive and non-invasive and non-identifiable. So, you know, it's a pooled sample from all the people in a building. So all of the advantages that come in terms of anonymity and in terms of resource savings that come from pooling material from everyone in the building into one sample, we're getting those with wastewater. And as I mentioned, right, there's like a few different kinds of buildings and building level communities that use wastewater monitoring, and they use wastewater monitoring for different applications. For congregate living settings, like a correctional facility, the application that we see that's really important is about detecting outbreaks and mitigating outbreaks of COVID-19. So to tell you what I mean by that, imagine that you have a building and a population where you don't have wastewater monitoring. And imagine on day one, everything looks fine, no one is sick in your facility. And then a few days later, you have a report that one person is symptomatic and they get tested and you learn that they have COVID-19. Now there's this question of, is this just a single isolated case, or is this the tip of an iceberg of asymptomatic cases, or other people have already been infected and have yet to develop symptoms? And then maybe by day 5, you see there's a bunch of people who are infected. And that'll be your signal based on the fact that a number of people are symptomatic and seeking tests. That will be your signal that there's an outbreak, right? So it takes you the time for someone to get infected, become symptomatic, get a test, and those results come back. And then that has to happen enough times to detect that an outbreak is happening. And the nice thing about wastewater monitoring is that you can short circuit an outbreak growth a little bit, because wastewater monitoring can detect people who are infected even if they're asymptomatic. So maybe in this imaginary story, maybe on day 1 there was already someone who was infected, but they were asymptomatic. They were never going to show symptoms. Wastewater could pick up that signal, and then maybe by day 3 there's enough people who are infected that from the wastewater data you can conclude as a facility, as the building administrator, that we should take some action, and it can be that mitigation will stop the growth of an outbreak, right? So the point is that wastewater on its own can't prevent an outbreak, but it can give you the information and the data that you need to take action with greater confidence and potentially earlier on. The way that a lot of folks use wastewater is, interpret wastewater data is in terms of detect or non-detect. So now no laboratory test is perfect. They'll have what's called a limit of detection, which means that if you don't detect the SARS-CoV-2 virus in wastewater, there's no guarantee that there's actually exactly 0 virus in wastewater. But if you can't detect it, it's some signal. If you can't detect the virus, it's a signal that there's a small number of people and perhaps none in your facility who are infected. Whereas if there's a detection, it's a signal that there might be 1 or more people infected. And this is pretty common practice in the scientific literature in a lot of places. At BioBot, we found that this was sort of insufficient for folks. And so one of our areas of developing work, and something that we're trying to roll out to folks, is something we call risk tiers, which is to break down detection into different tiers of risk. So the point here is that wastewater data comes back as a quantitative number. It's not just detect or non-detect, but the information that comes back is in a format that's pretty confusing. It's viral genome copies per liter of wastewater, which is hard to interpret. So what we've tried to do with this risk tier system is create some kind of qualitative guide to turn the quantitative information into some kind of system that can help you understand whether this is a big number or a small number. And the way that we develop these risk tiers is based on data, including from places like correctional facilities, where we were able to link the wastewater data with later ascertainments of how many cases were there. And we called this high risk category places where there were a substantial number of cases. It wasn't that there was 1 or 2 filtering around, but substantially more than that. And the nice thing once you have risk tiers is that it gives you some sense as a building administrator of how you should modulate what your response is going to be. So if there's no detection, then you get some confidence that whatever mitigation measures you have in place are good, or maybe you even want to roll back some mitigation measures and ease restrictions in your community. If you have low risk, maybe you want to add in some less onerous mitigations. And if if the wastewater returns a high risk number, then maybe that's time to consider maybe testing everyone in the facility to determine the exact extent of an outbreak and make sure that you can break chains of COVID-19 transmission. And as a way to wrap this up, I'll show you a picture. This is some real data from a congregate living setting that BioBot works with, just to give you a sense of what a time series could look like. So this facility had been sampling with us for a while. Over the course of many weeks, they had been getting detects or very low non-detects or very low level detects. So those green dots and those blue dots at the beginning of the time series here. And what you see at the time that we've called day 17, they started to get some slightly higher numbers that we would call in the medium risk category. And so the administrators of the facility, they started to pay more attention to the wastewater. They started to get all their ducks in a row so that if they needed to take action, they could. And it was shortly after that they took another wastewater sample that came back with a concentration of the virus that was much higher than ones they had gotten before. It fell into our high risk tier. And based on that high detect, they immediately started testing everyone in the facility using rapid antigen tests. And they found that actually there was a substantial number of people in the facility who were infected and who either hadn't developed symptoms yet or who were going to be asymptomatic cases. Those folks were quarantined in a separate part of the facility. And this contained the outbreak. So you can see, right, that it didn't just continue to grow. There were still more people in that facility who could have been infected. And so wastewater gave the building administrators the information they needed to take swifter action. So on day 24, when they got this high wastewater detect, they had no other indication that there was a COVID-19 outbreak at their facility. It was only because the wastewater testing returned this high risk number, and then because they took that as a trigger to go and swab everyone, that they found out that there was this outbreak and then were able to take action to mitigate it. My slides are moving very slowly, but the next thing to say is that when it shows up on the screen is that, you've heard about this work for opioids, about wastewater monitoring for opioids. We just talked about COVID-19, but there's no reason that a number of other that you can't measure, like Nushu was saying, anything else that goes into your body and comes out through waste products from the body. So things like influenza are high on the list. Influenza does get excreted to a small amount in stool, and we expect that in the future it's going to be really important to understand as a facility whether you have a COVID outbreak or whether you have an influenza outbreak, even though the two might be difficult to distinguish based on their symptoms. As Nusha mentioned, there's the potential to test for a number of high-risk substances, not only opioids, but also meth or other kinds of chemicals that might not be bad on their own, but depending on the setting that they're used in, could signal that there's a problem with security or something like this. And then also gastrointestinal diseases, of course, are excreted in stool. So there's reports in the scientific literature of wastewater monitoring being used to detect things like Hep A, norovirus, and salmonella. There's a lot of work to be done to determine whether we can actually make these work in the lab and whether they're useful in the hands of building administrators and public health officials. But I think the lesson that we took away from the COVID-19 work is that wastewater monitoring is only going to become more and more integral part of our public health system in this country.
Thank you. That is
absolutely. Thank you. That was great. That was great. Questions people have? Nor if you can call people because I can't see them.
I have a question.
Yeah, Bob.
Scott, I'm curious. The Bridge Club at Greater Lowell kind of fits the bill for this type of situation, I think. We have a pretty wide
Is it connected to a printer or an aid?
Try hitting the right clip.
Somebody.
I
think that's somebody else, Bob. Go ahead.
I'm sorry, you buy up?
Go ahead.
Yep, go ahead.
Okay. Scott, the application as far as the building level sampling, my million-dollar question is, how does sampling take place, wastewater sampling take place in a facility? Because I think that the Bridge Club, for example, we're a clubhouse style recovery center, so we have a pretty wide array sampling of people, both demographic and a pretty wide economic scope as well. Everything from homeless to functioning alcoholics to the doctors and lawyers. And I'm just curious, how do you obtain samples from an established sewer system, quite frankly?
Yeah, we have an environmental engineer at the company, and we work with usually the facility manager at a building. For the most part, right, like one of the advantages of wastewater monitoring is that we're piggybacking off of existing literature, existing infrastructure, sorry. So in most buildings, there's something that's called a sewer cleanout, which is a place in the building where the facility manager can already take sewage samples, which are used for other reasons, right, to make sure that the sewer system is working. So what we do is we work with the facility manager to get a sampling device installed at that location and plugged into the existing system.
Okay, that was my question. Thank you.
Thank you.
Mike Hugo, you had a question?
Yes, thank you. First of all, it's not really a question. I want to make a comment that while this all seems like alchemy to some people, maybe, in public health, I'm working very closely with a number of boards of health, as most of you know. That's my job. And I just want to say that about 2 or 3 weeks ago, I was talking to the health director in Nantucket, and he said to me, and Nantucket is one of the people that uses your system, Scott. And he told me, he said, we're gonna have 14 cases this week. And I said, well, how do you know that? And he said, well, the wastewater samples are telling us we're gonna have 14 cases this week. And people who have actually got it down to the science of the science and really understand how it works are actually able to predict for their municipalities, in that case, municipality / island / county. But it really does work, and it's incredible. And I just want to thank you guys. You know, I've wanted to meet you and thank you for what you've done, because what you've done is making a huge difference in our ability to do monitoring and predictions. And we can see the hotspots developing because of your technology, and you guys really should be congratulated. It's incredible what you've done.
Thanks. Yeah, and it's really good to hear this too. I'm glad to meet you too, Mike. I mean, what we've seen across different communities in the United States is some collection of different folks who are interested or not interested in wastewater-based monitoring. So sometimes it's the public works people are excited, but the public health people aren't, and the elected officials are, but someone else isn't. So it's just so exciting to see in Massachusetts that the whole triumvirate is there, right? That the public health is on board, elected officials are on board, wastewater monitoring is on board, you know, wastewater specialists, because it really does take this integrated community of people to make the most of this kind of data. So happy to hear that.
Thanks. Any other questions for Scott? If not, we will move on. Thank you so much, Scott. And I know Nusha had to jump, but please express our gratitude to her, and we look forward to seeing you both.
Our pleasure. Thank you.
Yeah. And oh, Susan, you had a question?
I think thumbs up.
Okay. All right.
Thumbs up. I love the knowledge.
Oh, thanks.
Thank you.
Thanks. No worries. Okay. Marion,
Thank you
back?
both. Thank you both. That was great. You know, it is. This is just amazing work. It does. The first time I heard this, it did sound like magic. And we had no idea that it would become so vital during COVID. So thank you. And thank you for making the time to be with us.
Our pleasure. Thank you.
Thank you. All right, switching gears, we turn now to Ashley Hall. And many of you know Ashley. Ashley is the program director for the Northeast Tobacco-Free Community Partnership. And the partnership is sort of its base mission supports communities' efforts to lower smoking prevalence and the exposure to secondhand smoke. And they do that by talking about some of the tobacco industry tactics, mobilizing the community to adopt evidence-based policies, and really, most importantly, changing social norms. And Ashley's here today to update us on where we are after a year of the kids being out of school and kind of being by themselves a lot in the vaping and tobacco world. And one really scary statistic that's recently come out is that just one 30-minute session with a vape pen, and if you know kids who are vaping, 30-minute session happens much more than once a day, can cause stress that leads to lung damage and puts a person at risk for heart or neurological disease. And there's lots of reasons for that, about how they damage oxygen cells and make tissue damage. But that tissue damage, even if kids aren't seeing an impact right now and they're thinking, I'm only vaping and it's all really safe, can make them much more vulnerable to heart disease, cancer, diabetes, Alzheimer's, and other conditions. We just know that nicotine, however you get it, whether it's a cigarette, a cigar, or a vape, is very addictive. So I want to thank Ashley for coming back to give us an update. Thanks, Ashley.
Thank you, DA Ryan. Thank you, everyone. Good morning. Good to see all of you. Some new faces to me, some faces that have probably seen me present many times. But this will be more of just an update kind of on the landscape of tobacco since COVID and some resource updates as well. So DA Ryan gave me a great introduction, but I am a program director at Greater Lawrence Family Health Center. I see our Northeast Tobacco Free Community Partnership, which is what I'm here about today, but I'm also the center director for the Merrimack Valley AHEC. So it's both of these programs are housed at Greater Lawrence Family Health Center, but the Tobacco Partnership is funded by the Massachusetts Department of Public Health, specifically the Tobacco Cessation and Prevention Program. So there are 8 offices in the state of Massachusetts who do exactly what I do. We all just have different regions of the state respectively. And actually, 2 of my colleagues are also on this call. My colleague Colleen, who has the Southeast region, and my colleague Nori, who has Central Mass region. So if you happen to be in one of these border towns that might not be in the Northeast, we are happy to connect you with the community partnership who is in your region. This is just our disclosure to let you know that we are coming from a public health perspective, because believe it or not, there are still scholarships, research labs, et cetera, that are funded by the tobacco industry themselves, but we are not coming from that lens. My last little piece of kind of the housekeeping is that when vaping came out, we started to call vaping, vaping, and then we started to refer to cigarettes as kind of traditional tobacco. But keeping in mind and keeping equity on the forefront, we want to just remind people that traditional tobacco is actually not the same as cigarettes. So traditional tobacco, that vocabulary refers to the sacred way that some American Indian communities have used tobacco for ceremonial or medicinal purposes for centuries. Whereas commercial tobacco is what we usually mean by cigarettes and cigars, et cetera. This is the addictive tobacco used for recreational use that's linked to cancer and everything with the chemical additives. So just a reminder to make sure we are using the correct language when we talk about tobacco. And if you're interested in learning more about this, Keep It Sacred is a whole network dedicated to this information. So you can go to their website to learn more. Housekeeping aside, so we do want to talk about, this presentation is mainly focused on updates in terms of tobacco with COVID-19. So when COVID started to hit, I'm sure all of you on this call know that it takes a long time to get definitive health research. So what we do know to begin with is we know that COVID-19 is a virus that attacks the lungs, and we know that smoking and vaping of any substance also attacks the lungs. Therefore, we know that anyone who smokes and vapes any substance is putting themselves at higher risk for a serious infection of COVID-19. What we know, this is straight from the CDC, is that this is a study that they did a couple months ago. Individuals with a history of smoking are over 9 times more likely to develop severe illness with infection with COVID-19 versus those with no smoking history. Reasons for this is that when you smoke and vape any substance, especially tobacco or nicotine, your lungs immediately start to get inflamed and their immune system response is shut off. So when the virus comes in, your ability to fight off the infection is much weaker than those who do not have a history of smoking and vaping. So that's why we're seeing the more severe cases among some of those who smoke and vape. Especially, we know that what can make all of that worse is tobacco that has flavorings like menthol, really increase that inflammation because they're just not chemicals that are meant to be in your lungs. So honestly, this is just, sometimes people who work in the field are hesitant to talk to the people they serve about smoking and vaping, but COVID-19 is kind of a good foot in the door to get that conversation started.
And I'm at a Zoom meeting with DA Ryan, but go ahead.
So anyways, this is just a really great time to talk to the people you serve about quitting smoking and vaping as kind of a talking point to get that conversation started. This data, like I said, it takes a long time to get definitive research, but some of our epidemiologists were involved in the COVID-19 community impact survey, which you may have seen sent out a few months back. The results were sent out on June 8th. We didn't specifically ask only about tobacco. This was a large survey that measured a lot of impacts of COVID-19. So one piece of the COVID impact survey on youth was about substance use. And so what we saw is that some youth started to use substances in general, more during COVID than before. What we know is that youth living in rural areas were significantly more likely to report more substance use than those in urban areas. As far as type of substance used, it kind of depends, but overall trends are starting to show it's more alcohol use than before. I always say to take youth substance use data, that self-report with a grain of salt, because if you work with youth, you know that when you ask youth about their substance use, they're very scared of getting in trouble. Even though how many times you tell them it's confidential and that you just want to see the numbers, they tend to be a little more reserved because they're worried about getting in trouble. So, but this is what we're seeing as far as kind of overall statewide community impact surveys with substances. When we looked at it down by race and ethnicity, Hispanic and Latinx youth were reporting 2 times more of a lot more substance use during the pandemic than before than any other race or ethnicity. So just something to keep in mind as well. And what I'm going to do when I'm done presenting is that both of these reports are public information. So I'm going to put the links in the chat to these surveys as well, so you can see the full landscape of these surveys, because this is one very small piece of all the work they did. As far as the adults community impact survey, we saw that 41% of adults that took the survey say their current substance use increased compared to pre-pandemic. And of those who had increased substance use, this is kind of broken down by it's kind of hard to see because it was a screenshot of a very large data set. But this is kind of the substance that they said was being used. So tobacco was kind of in the middle there, but some of the drugs that a lot of this group works on in substance use prevention were at the top as well. So just interesting to note. And again, I'll put the links in the chat box so you can read these full surveys if you're interested. As a reminder, some of the reasons that we're seeing lower tobacco use is because of the laws that we passed in Massachusetts. So in December of 2019, we passed this law called an Act Modernizing Tobacco Control. And if you think back, all the way back to December of 2019, January, February, March, going into 2020, that's when COVID was starting to really incline. So we saw a little bit less of this law in the news because COVID was really starting to skyrocket. So as a reminder, we passed this law. It does many, many things, but the biggest thing that in our opinion is driving down tobacco use is we removed all flavored tobacco from store shelves in Massachusetts. So you can't walk into in theory, if the law is being followed, you cannot walk into a gas station and see them selling mango flavored Juuls, Puff Bars. So that goes for vaping products, and it also goes for commercial tobacco like cigarettes. We also banned the sale of menthol tobacco, and that was a huge public health, but also health equity win for us. Massachusetts became the first state in the country to substantially restrict the sale of menthol tobacco. So this was a really, really big win. For us now, usually this is the time when somebody chimes in and says, yeah, but what about New Hampshire? So yes, we do have the distinct pleasure of being on the border of Massachusetts. So to answer the question that somebody will most likely ask, is that our goal was to be the first state to do this and have other states follow in suit, because it was kind of like someone needed to take that first step. And so we were that someone to do this first. And we're talking to our neighboring states and to also hopefully do the same. It's just, as I'm sure you all know, boards of health are very overwhelmed with all things COVID right now. So we did launch a campaign to educate the community about this law, to understand the importance of removing menthol tobacco and its ties to racial justice. So for decades, the tobacco industry has specifically targeted Black, Latinx, and LGBTQ plus communities with menthol tobacco. And this whole campaign is aimed at it, telling people why and how. So if you have the time and if you're interested in understanding why this law was passed, the campaign is called No Menthol, Know Why. We have videos of people in Massachusetts who were previous menthol smokers. So it's all real people, even some youth in Massachusetts getting involved with the campaigns. We've got virtual Zoom backgrounds, we've got videos, we've got letters to the editor. So just a reminder to let people know the importance of this law. We also know that menthol tobacco, yes, we took it off the shelf and that's great, but we also know menthol tobacco is easier to start smoking and harder to quit. So we're taking it away from people. We want to make sure we give them the help they need to quit. We're not just going to take it away and leave them without the help that they need. So we have at the Massachusetts Smokers Helpline a menthol incentive program where users get a $50 gift card for help quitting menthol tobacco. They get $10 after their first coaching call, $15 after the second, and $25 after the third. So the amounts continue to increase to incentivize them to keep it, continuing the program until the end. They can enroll online or they can call to enroll. And we have little informational cards that you see down here on the right that kind of advertise this program. If any of you are from the Lawrence area, you might recognize this woman here. Her name is Evelyn, previous menthol smoker, cancer survivor, mother and grandmother turned into substance use advocate. So pretty cool that we have our own local stories highlighted in this campaign. Continuing on resources, since this is such a great time to help the people you serve quit. Our biggest resource is the Massachusetts Smokers Helpline. So that menthol incentive is a part of our whole help quit line. So this program is free for anyone as young as 12 for any type of tobacco that you use, whether it's cigars, vaping, chew, whatever it might be. You can enroll online or you can call, and as long as you're 18 or over, you can get up to 8 weeks of nicotine replacement therapy. So that's things like the patch, the gum, the lozenge, etc., delivered to the person who's trying to quit in the mail completely for free. So you can go online to click around on their website. It's super user friendly. So you can see if you're someone who is trying to quit, it's really user friendly. You say, I want to enroll right now, or I'm just looking. It's very straightforward. We also have information on there about smoking and vaping with COVID-19, and the website's available in English and Spanish. If someone does not speak English or Spanish, they can call, and we have translators for over 190 languages. So I can almost guarantee you that if you are helping someone who does not speak English or Spanish, we still have a coach to help them through their quit attempts in their language as well. If you are a healthcare provider in any sense, you don't have to be a clinician, you can be a school counselor, whatever it might be, I encourage you to click on this tab up here, and it shows how you can refer people to the quit line. So that's kind of a whole different presentation, but just to throw it out there that you are able to refer someone to the quit line, which is really nice because it takes the burden off of the smoker of saying, oh, you want to quit, call this phone number. This lets you put their information into the quit line, and the quit line will contact the person who's interested in quitting smoking, excuse me. So this is something that's probably new to a lot of you. And this is our special programs for priority populations. So you've all heard of, me most likely talk about the quit line, but we also have these special programs for people who are at a higher risk for smoking related diseases and need extra help quitting. So our first program, and I'll just also say that we are in the process of finalizing promotional materials for these programs. So hopefully in the next couple of months, we'll have little cards that you can hand out to people, like if you work with WIC or if you are a behavioral health provider, that you can hand out to these priority populations about these programs. So we have the perinatal program for women who are currently pregnant. The regular quit line program is about 5 coaching calls, and each time you call, you get connected to a different coach. The perinatal program, you get 9 coaching calls, and you get the same coach through the entire program to help develop that really close support. 5 calls during pregnancy and 4 postpartum. And in this program, you get up to $65 in a MasterCard gift card, which is really great because that can be some nice, easy diaper money to get the new mom started. So this is on the phone. You can also enroll to get automated text messaging and email so that even when you're not on the phone getting that coaching support, they are getting reassuring messages to their phone via text and email. We also have the behavioral health program. So this criteria, this is a newer program, so we're just starting to get used to it, but these are the conditions that someone has to self-identify that they have if they're 18 or over at intake. And then we say their preferred language is English to start for the intake, but then again, we have those translators for the other languages. They get 7 coaching calls and they get the free 8 weeks of nicotine replacement therapy. The difference with this program is that the coaches are specially trained in how to help people with behavioral health diagnoses quit their tobacco addiction. Our American Indian commercial tobacco program, again, since this is really important because many people in the American Indian community feel conflicted between their use of sacred traditional tobacco versus commercial tobacco. So in this program, all of the coaches are also American Indian. So they identify and understand the culture. They get up to 10 coaching calls. They have their own phone number and their own website with specifically tailored messages. And again, everyone's eligible for that 8 weeks of medication. And I'm going to skip this slide for 1 second. These programs are specifically for youth. So we said, great, we have all these programs for adults. We have the quit line, but we didn't have anything for youth, kind of our high school aged kids who are specifically using vaping products. So we have 2 programs designed to help youth quit vaping. This is Quitting is powered by the Truth Initiative, and this is an automated texting program. So all kids have to do to enroll in this program is text this keyword, I'm sorry, you can see my mouse, this keyword to this phone number, and they're automatically enrolled. And then for weeks and weeks and weeks, they get automated messaging about how to help them quit. This program is really unique where youth can text specific keywords based on what kind of coaching they're looking for. So if they had a craving, they can text the word crave. If they had a slip, they can text the keyword slip. If they just want more info about vaping in Massachusetts, they can get that too. So this is just automated text based off of what the youth is responding back. So that works really great for kids who are really scared of getting in trouble and don't want to pick up the phone and talk to somebody. But there are some kids who say, I won't really check my phone, a text message won't work, I need to talk to another live human. So for that, we have My Life, My Quit. These are trained live coaching specialists on the other line. Youth who are designed to help youth quit vaping. They can call or text, but either way, they're going to get a live person on the other line to help them quit their vaping attempt. We also have teen.smokefree.gov. That's a national program, but both of these programs are specifically designed for youth in Massachusetts. This card that you see here on the right is a little bit bigger than a business card, and these are free, available at the Massachusetts Health Promotion Clearinghouse, which I'll come back to in a second. So you can download these electronically or have them delivered to your doorstep for free. And these are really great to have out in schools or in town halls, etc., places where youth are going frequently, so they can grab them. And on the front, it has this checklist to see, oh, wow, these are the signs of addiction. I might be addicted. And on the back of the card is all of this information you see here typed out of where they can go for help. They're nice because they're really small, so you can discreetly grab them and put them in their back pocket. So we said, okay, we've helped adults, we've helped youth, then we kind of have this gap of kids who were in high school during the vaping epidemic skyrocket a couple years ago, but now they're young adults in college. So the Massachusetts Smokers Helpline also developed our young adult vaping program, so designed for the specific age group of youth, and the coach will help them specifically quit the type of tobacco that they are using, and they have their own text and calling
Mike.
as well.
Hello?
So the Massachusetts Health Promotion Clearinghouse, like I mentioned, is a completely free resource. You might use it for topics other than tobacco. They have everything from tobacco to domestic violence to COVID-19 and everything in between. So on that website, you'll find posters, stickers, brochures, business cards, etc., of things that you can download or order completely for free to hang up or use in your organization to reinforce quitting messages. We know that the more people see quitting messages, the more likely they are to take action in their quit attempts. This is a really great resource. And sometimes people will call me and they'll say, this is the population I serve. This is the kind of organization I work in. Which material should I order? So if you're interested in getting some guidance on what kind of materials you should get, I'm more than happy to help. We have a couple new things on there, including a nurse's guide. So if you work with school nurses, we have a brand new guide that school nurses can use with their youth to help coach them through a quit attempt as well, right within the school. If you've worked with me previously, you may know that our website was getting a little bit out of date. MakeSmokingHistory.org is no longer. Our website has merged onto mass.gov. So youth can go to mass.gov/vaping. And all of our campaigns are brand new. They launched within the past month or two. So our youth vaping campaign is called Facts, No Filters. So this is all videos designed specifically for youth. So it uses kind of social media, bright colors, pictures of people their age to talk about the dangers of vaping. We have our adults those pictures are flip-flopped. This yellow picture is the youth campaign. The picture above is the adult campaign. We have our adult page, so mass.gov/getoutraged. And on this page, you'll find facts about vaping, information for parents and guardians, and information for school organizations and providers. We are in the middle of upgrading and updating our school toolkit. So we have a toolkit on there for schools of what they can do to help address vaping within their school. And then lastly, we have a cessation campaign that is not yet launched. It's going to launch hopefully in October, but that's a brand new website as well. And it's all about taking the first step towards a nicotine-free life. If you are interested in promoting any of these resources, I have many materials for you to do so. I have still images, which are great for social media, but also really good to have like on the TV of a waiting room. The still images have QR codes so people can easily scan their phones and be brought to the website. I have quick videos, I have blurbs for newsletters and blogs, and even have Zoom backgrounds. So I'm more than happy if your organization is interested in helping promote these campaigns. We can work together to do that as well. So that is my quick update. So I think I saw some stuff coming in the chat.
Yeah.
So there's some questions there, Nora, if you want to help me navigate that.
Yeah, so thank you, Ashley. That was awesome. And I was kind of like, oh, should give us a little update, and the amount of information is fantastic and it's really well directed. So I appreciate that. So Devin had asked whether the menthol incentive program is only for menthol products, or could it be used for cessation of other nicotine products like vaping or unflavored commercial cigarettes?
So hopefully, Devin, I kind of answered that question. So the menthol incentive program is only for menthol, but the Massachusetts Smokers Helpline is for any type of cessation, if that answers your question. If it doesn't, you know how to reach me.
That was great, thank you.
Yeah.
Devin, that was good for you? Okay. And Susan had mentioned, Susan, do you want to jump in and talk about?
Hi. You know, I was really surprised that I had 2 clients. I'm not a clinician, so I'll, lean to any clinician or your advice that was told prior to surgery, they're smoking, they're big smokers, and they were told to go vaping instead. And I was like, oh, they didn't say just stop or the patch. And I was like, what vape would be a good all healthy alternative to change? And I was shocked.
Yeah, I'm like my skin is a little bit crawling hearing
Yeah.
that story. It's something that I'm not a clinician either, but this is the information I give for a living. It's a question I get a lot is, well, isn't vaping healthier than smoking, right? Isn't it better for you? Healthier, even if that was the case, healthier is still not healthy. You should not be inhaling anything other than clean air into your lungs. So I'm very surprised to hear that
it was a doctor
suggesting that. There's extremely limited research about people who switch. Usually what we hear of what happens is that people say, well, yeah, I'm going to quit cigarettes and I'm going to go to vaping. But they end up being what we call dual users, where they still like their cigarettes for one reason and they like the electronic cigarettes, the vapes for another. So they end up using both. There's just a lot of misconceptions about vaping. Like we could have a whole session about debunking the myths. Many people still, even my own doctor, I was sitting in my doctor's office for my annual physical and I told my doctor what I do for a living and she said, oh, that vaping stuff. Yeah, kids are just inhaling water. This was my doctor, a clinician. And I said, vaping is not water. So I give a lot of types of presentations. So I give one whole presentation about what vaping is, which if someone's interested, I'm happy to do that for you. But quickly, it's not water, it's formaldehyde, it's acetone, it's nicotine. So it is definitely not healthier.
Okay, because I thought that that's what they might have thought, that you could actually change it to water. And I'm like, I'm not even touching this. Go to your own PCP, because these doctors, I don't know what they were talking about. But
yeah, you definitely are correct. The best thing to always do is refer to someone, to their clinician, because each person's addiction and tobacco use is different. So that's always step one. We also just need to make sure that clinicians are trained in this to know that it's not just water. So I'm happy to talk offline if you want to learn a little bit more.
So it's a misconception though, that you can't just vape with water. Like you don't do that. Okay, thank you.
Yeah.
All right.
Not water.
Thanks.
Ashley, thank you so much.
Thank you for having me.
We may take you up on that coming back. Thank you. Just before I turn it over to Laurie, I just want to mention a couple of things, because I may not still be on by the end, but I just want to remind folks that this afternoon from 2 to 3, although it will be recorded, the National Council for Mental Wellbeing, who will be here next month, will be presenting the latest in its Wellbeing Wednesday. So we'll get the link to you in the chat. And also coming up, we would ask you to consider joining the Healing Community Study and RISE Massachusetts on Monday, October 4th from 12 to 1. And this is important because this session is going to explore RISE's Your Right in Recovery Toolkit. There'll be a panel, some question and answers on advocacy efforts to navigate housing, legal issues, employment systems. So we'll put all of that information. RISE will also be joining the Wellbeing Group for next month. And one of the things they're going to be talking about, and we are going to spend a lot of time in this group because I'm doing a lot of work statewide on this, is RISE will be talking about this project and their $800,000 grant to address equity and treatment. So the good news is there is a fair amount of federal money coming to Massachusetts around substance use. The need is to make sure that that is being used, number one, with really looking at projects with an equity lens, and number two, that it's being used for projects that are very effective. And to me, most important and a basis of all of our work, that it is the decisions are being made with the voices of the people in recovery at the table. You know, I've been a strong believer from the beginning that people who have reached some stable recovery are great sources of information about what people need, and we should be including them. And I know Laurie's going to talk a little bit about the event that we're doing on September 30th. And I know Bob Fox, Nora, if you could let Bob at the end, has a little bit to talk about the Bridge Club Gala. But before we do that, I want to go back to what I said at the beginning, and thinking about September is Suicide Prevention Month. And I'm very happy to welcome back, and she's been a great source of information for us, is Laurie Krinsky, who is the president of NAMI of Central Middlesex. And Laurie is really a critical member of the Mystic Valley Behavioral Health Coalition. She works with the folks from WellForce providers in Melrose, Wakefield, Medford, and the surrounding communities. She's been just a really active member of this task force and a great resource for us. So I think she's going to talk a little bit today about what we started with, which was how do we improve the way that we're talking and thinking about mental health. So Laurie, welcome back.
Thank you. Let me put my presentation up here. I do want to apologize a little bit because it may have been a slight miscommunication on what I was going to present today, but what I have for you today is basically information about NAMI, and I hope you'll find that helpful. Given some of the other conversations that's been going on and the concerns about increase in suicide, I want to offer just a couple of sentences to start about my hope for change in the Commonwealth. And a lot of that comes from the fact that our legislators, both at the state and federal level, after decades of advocacy and a little kick in the pants from COVID, are listening and paying attention and making some changes. The Massachusetts legislative budget for next year is exceptionally favorable to behavioral health compared to previous years. We have the Health and Human Services Department offered up a roadmap for behavioral health reform at the beginning of the year, which needs lots more details to it, but it's a structure to hold on to going forward. We have lots of money coming in from different federal sources, additional Medicaid for mobile crisis response. Some of the COVID money coming in will go to behavioral health supports. The SAMHSA money is going to be higher than it's ever been before. And we have money coming in for a switch to 988. So with that, fingers crossed kind of thing, I'm going to switch over and talk to you about what NAMI has available to help people who are in trouble. This presentation focuses on my affiliate specifically, but I'm going to add in a couple of comments about what else is available at other affiliates within the state. There are multiple affiliates who just cover the Middlesex County. So if you don't see the name of your town there, there's another NAMI affiliate that will answer your calls. At the top is our basic mission statement, 3 words, end it, education, support, and advocacy. And you'll notice those topics going forward. As I said, there's the list of our affiliate towns that we take care of, but there's many others across the state. When people think of NAMI, they mostly think of support groups. And yes, we do have those, 2 different kinds, one for peers, the people who are concerned about their own mental health, and more uniquely for family members because mental health conditions affect everybody in the household. We also offer educational programs split the same way for family members and one for peers, and also a third one for parents of younger children. These are free. Everything from NAMI is free, and now they're all on Zoom. So it's easier to connect to a support group. You just pick the one that matches your schedule and sign on up. Right now, the best place to do that is on the NAMIMass.org website, and all those options are up there. We also have some specialty support groups available for people in the BIPOC community, family support groups in Spanish. So take a look on NAMIMass.org and see if there's a match to the need of the person you're helping. Something that's unique to Massachusetts is the NAMI Compass resource line. This is a giant database of all the mental health octopus that doesn't connect to each other resources in the Commonwealth. So anybody can call this. Clinicians are welcome to do so. Family members do that. People with mental health conditions call that. And what we do is we help you navigate your way through the Massachusetts mental health system and help problem solve in difficult situations. We get a lot of calls about housing. We can't, get it all set for you and get you a housing thing, but we can listen to your background and point you to the best of many options for you to peruse. Next, we have the NAMI community programs. These are available to bring to your location. Again, almost everything is free from NAMI. In Our Own Voice is a public program of 2 peers telling their story of recovery. It matches up with a video component. There's lots of time for questions and answers, and those people will share anything. They're amazing. We have those available virtually now, and eventually we'll bring them back to community organizations or companies. Ending the Silence is a 50-minute school program for classrooms. That's to get kids to start talking about what they're feeling. Allies for Student Mental Health is for professional educators. That one does have a fee. You can do that program to teach teachers how to recognize problems in their classroom. We have strong advocacy efforts. We have an advocacy day at the State House every year, and we continue to lobby and testify and try to move things forward. And NAMI Walks is our annual spring fundraiser. We get about 5,000 people downtown, and it's also a stigma-free day. So that what makes it different from every other kind of event you can join. To move on to just a couple of things that are unique about our affiliate. Right now, you see some pictures there from our Scarecrow contest in Acton. It's our Stand Up to Stigma Scarecrow contest. It's lots and lots of fun, and it's easy to donate a little bit of money to NAMI Central Middlesex. In February, we're hoping to have our second Faith Communities and Mental Health Forum. In lots of instances, somebody who might be having symptoms might turn to their faith leader for help, and that person is not trained or cognizant of how to move forward. This is the second time we'll be doing this. We took a program from Austin, Texas, and reoriented it to our own needs and desires. Had about 60 attendees last time, hopefully more this time. And if we end up on Zoom, everyone can come. Another program that we have that's unique to our affiliate is our college panel program. This invites families who are sending a child off to school who has a mental health concern. There's lots of things to learn, lots of things to understand, communication things, HIPAA privacy laws, how to negotiate, how to communicate. We started that last year. We had that for the first time via Zoom, doubled our general attendance. We used to have it at high schools. We're doing this, I think, year 9 coming up. Very successful program. On the last page here, we have the first item there is our crisis cards. We produced about 600 of those, 6,000 of those, I'm sorry, within our affiliate. We offer those to police departments. And what you can see on there is crisis information, contact numbers, and some NAMI materials that help you plan ahead for crisis. Now, these are going to become obsolete next July when the 988 number that's being supported by the federal government comes up, and that's going to replace the National Suicide Prevention Hotline number that Nora posted. So that'll help, you have a physical crisis, you call 911. Now you have a behavioral health crisis, we'd like you to call 988. And that's going to connect you, instead of to a police department, that will connect you to a behavioral health person, specialist. So that can make a big change across the country and a change in our state to move towards behavioral health reactions on crisis situations. The next item on there is some behavioral health resource flyers that we put together fairly recently with Emerson Hospital in Concord, and could do for other hospital units. We're in the early stages talking to Melrose Wakefield about that. And these are flyers that focus on free supports. NAMI's not the only person out there who offers free support groups. The topics include adult peer support, family supports, child and youth supports, crisis resource information, how to locate a provider. Lots of people don't know how to do that. Usually your PCP tells you where to go for a new orthopedist. No one's going to help you find a therapist. Substance use, and we have another one called criminal justice involvement, and that one includes the Central Middlesex Police Partnership and the Concord District Court Jail Diversion Coordinator, which is now being operated by a new person. So we have to update our flyers to include her. The last item on there is speakers. I'm available. Some other people are available to come and do these kind of presentations. Some of the other affiliates also will have a public speaker program. Cambridge offers that often. And then the very last item I want to add on here takes off of what District Attorney Ryan mentioned, was our behavioral health workforce strategy session. And I'm not running that on my own. We're doing that through the Mystic Valley Coalition. But the idea for this is that we're going to invite behavioral healthcare service providers to come together. We're going to review some of the new opportunities that are happening in the state. We're going to listen to different speakers from a variety of perspectives. And then we're going to go into breakout sessions and talk about the potentials for tiered models of service. We've never had enough providers in the behavioral health system. With the increased demand with COVID, that's becoming more strained. So we want to get together and talk about opportunities. So my understanding is that Nora will share with everybody that invitation that's coming up on September 30th at 3:30. And you can all attend and participate on that event. So I try to talk quick, so we have a little questions left over. Does anyone have anything that they'd like to ask?
Questions? That was incredibly helpful. I guess all of, from my perspective, so much of this is geared to helping to destigmatize mental health and to make having conversations about behavioral health easier and more accessible.
Right. Well, that's our quote for our scarecrow contest is our goal is 100 scarecrows along the fence and many conversations about mental health. So we've gotten up to 70 scarecrows, so we need a few more to make our goal.
That's pretty great. How long does that go on?
Well, they're accepting scarecrows now. It starts in September every year. This is year 6. So people stop by, pick up their frame, go home, make their cool scarecrow, bring it back, and then we put them up on October 1st. And then the community can come in and vote. You have to pay $1 for every vote, but you can vote as many times as you want. And then we announce the winners at the end.
That's terrific. That's terrific. Any questions or comments? Thank you again. Lori, thank you so much. In the DA's absence, I just have a couple of housekeeping matters. I want to point out that our meeting next month will be at an earlier time. We're going to start at 9 o'clock and we'll run to 10:30. And as Marian mentioned, we will hear from the National Council for Mental Wellbeing, who brings a focus on mental health equity. And we will also hear from RISE, Massachusetts, and they will talk not only about the $800,000 in grants to support health equity in the substance use space, but they'll also talk about the Your Rights in Recovery program that they have and all of that information. So I will send out a save the date and a Zoom link for that. Please invite anybody you know who might be interested. And between now and then, I hope you all stay safe and healthy. And you all know how to reach me. If you have questions, if you have ideas for presentations, please let me know. Before I close this out, I think, Bob, did you have an announcement for the group? You're muted. Bob, you're muted.
Oh, we go. Is that any better?
There you go. Okay. Still can't hear you.
You got me now?
Gotcha.
Okay, sorry about that. Bridge Club of Greater Lowell is having our Person of the Year dinner, and we're honoring Jay Lenahan, who's the president and CEO of the Greater Lowell Community Foundation. And that is on October 6th at Lindsay's. It's a Wednesday night at 6 p.m. It's an early night. And we're very, very proud and very excited that we've been able to secure the services of the keynote speaker, Derek Sanderson of the Boston Bruins, who's a fantastic recovery story in and of himself, to speak about his own recovery. And that's at Lindsay's in Dracut. So pass it along if you can. We've got room. There's sponsorship available. It's to support the Bridge Club and Jay Lenahan. And again, it's going to be a great night. So we welcome and encourage anyone in the recovering community and beyond to please come support the Bridge Club, like I said, and Jay Lenahan. And that's it. So thank you very much, Nora, for that. And I appreciate it, and have a wonderful afternoon.
Thanks, Bob. And I'll send out your website when I do the follow-up so that people can figure out how to sign up. All right.
You can call the Bridge Club at 978-454-6191 for tickets, or my cell is 978-815-8994. The website's www.bridgeclubofgreaterlowell.org. Thanks, Nora.
That's terrific. Thank you. And again, I wish everybody a happy and healthy start of fall. And we'll see you next. Oh, I'm sorry. That's my friend. Go ahead. You got to unmute yourself.
Nora, can you hear me?
We can, yes.
Okay, you said that the next meeting was earlier at 9 o'clock, but what was the date of October's meeting?
It is, thank you. Again, without you, the glue that holds us all together, October 28th at 9 a.m.
Thank you so much. Thank you.
Wonderful, thank you.
Presentation.
All right, y'all, have a great, as I said, start to fall, and I look forward to seeing you all next month, October 28th at 9 in the morning. Take care. Be safe.
Yeah.